Good afternoon. Thanks, Elena, for the invitation to be part of this fantastic meeting. And it's a real distinct pleasure to be here to honor David Ilsen, who's been a wonderful friend, colleague, and mentor over the years, and really has been the person behind all of the work that I'm going to be talking about today. So I'm going to be talking about tailoring neoadjuvant therapy to tumor biology in esophagogastric cancer. So I'm going to start with just an overview of the neoadjuvant therapy options for esophageal and gastroesophageal junction tumors, and then I'll touch on the idea of really individualizing therapy and improving efficacy with the focus on how we use PET imaging to help assess response to therapy and then direct our therapeutic options, and then just a little bit of the next steps. So as most of you know, these are the 2018 NCCN guidelines for patients with esophageal and GE junction cancers. And the real primary treatment for patients who are medically fit is to do preoperative chemoradiation followed by surgery. And this is true also for both adenocarcinomas and squamous cell carcinomas. I'm going to primarily be focusing on adenocarcinomas. And then if you look at what the recommended concurrent chemotherapy regimens are, there's a whole host of options between carbotaxol, fluorouracil, and oxaliplatin, and then several of the other ones listed below. And that's really because there really hasn't been any head-to-head comparison of any of these options with radiation as part of neoadjuvant therapy. And we have all of these potential options because each of the trials over the years that has looked at the impact of neoadjuvant therapy followed by surgery has used a different chemotherapy regimen. So it makes the whole thing quite confusing. And so I'll just give you the brief background in terms of what the various studies have shown in terms of the neoadjuvant therapy options. This was the early study. These are some of the at least more recent trials that have looked at surgery versus pre-op chemoradiation followed by surgery. And this was the CALGB 9781 trial that was originally trying to accrue 500 patients. Unfortunately, they only accrued a total of 56 patients who were randomized to either surgery alone or standard 50-40 Senegray plus 5-FU cisplatin, which was really the standard regimen at the time, followed by surgery. And although they had such a small sample size, they still showed a significant improvement in overall survival for patients that received neoadjuvant chemoradiation, and their pathologic complete response rate among the patients that they had a response data on was 40%. So that was quite impressive even in such a small sample size. And then really the landmark study that has changed the practice for patients with esophageal cancer to giving neoadjuvant therapy was the Dutch cross trial, which randomized 366 patients. The vast majority had adenocarcinomas, and they received either pre-op chemoradiation with a dose of 41.4 gray with carbotaxol followed by surgery or surgery alone. And this study showed a significant improvement in overall survival with 5-year overall survival of 47% versus 34% for the patients who had surgery alone, and also and really impressive pathologic complete response rate for the patients who had squamous cell carcinomas of 49%, but still a reasonable rate of 23% in the adenocarcinoma group. And these are the Kaplan-Meier curves showing that there was this nice separation for patients receiving the pre-op chemoradiation. But also, when you look more carefully at by the histology, you see that difference is really driven by the squamous cell carcinomas. There was an improvement in the median survival between the patients that received pre-op chemoradiation versus surgery alone for the adenocarcinomas, but not quite as impressive. And so, suggesting that we still haven't found that optimal regimen. And then the SWOG 0356 study was a single-arm study that looked at a different regimen using neoadjuvant 45 gray, oxaliplatin, and 5-FU followed by surgery. And their primary endpoint was actually to look at the pathologic complete response rate. This was a phase 2 study to see if they should proceed to additional studies. They had a predefined efficacy threshold of a path-CR rate of 40%. They actually only had a path-CR rate of 28%, which did not meet that efficacy threshold, but it still is pretty similar to what we see on the other trials. And the median overall survival in this study was 28 months. The interesting correlative endpoint here was that the patients who had ERCC1 mRNA levels that were greater than 1.7 had a significantly worse progression-free survival and overall survival, suggesting that this is a prognostic factor. All the patients on the study received oxaliplatin, so we can't really tell if it was predictive or not, but certainly it was prognostic. And then the most recent study that's from the UK that's looked at the use of neoadjuvant therapy is the NEOSCOPE trial that showed they used induction chemo with Zelox, and then without any response evaluation or depending on response, they just randomized patients to either the 45 gray continuing with the Zelox or 45 gray with carbotaxol. And interestingly, this study showed that the patients who continued on the Zelox had a pass CR rate of only 11% versus the patients who switched to the carbotaxol who had a 28% pass CR rate. And their target to proceed was 27%, so they dropped the Zelox arm. And this is interesting in terms of what the findings that we've had from the CALGB study, which I'll talk about in a minute. So this is just the landscape of what we're seeing with these neoadjuvant studies so far in terms of all of the different options for chemotherapy. The radiation doses are different across the different studies. And the pathologic complete response rates are usually in about the 30% range, but ranging anywhere between 11 to 40%. And we know that from even old studies that pathologic complete response is associated with better overall survival. And so all of these studies were back over 10 years ago showing that if in the patients that had a pathologic complete response, that was a surrogate endpoint for, that could be used as a surrogate endpoint and was associated with better overall survival. So what have we learned from these multiple studies now that have been looking at the use of neoadjuvant chemoradiation? Well, it definitely improves outcomes. It increases pathologic complete response rates. It reduces the R1 resection rates and local recurrence rates, and it improves overall survival and progression-free survival. But despite that, in the cross trial, almost 50% of patients still progressed, and that was predominantly with systemic progression. So we really haven't found an optimal neoadjuvant therapy option for these patients. We have this nice therapeutic model for esophageal and GE junction cancers where we do neoadjuvant therapy, then surgery, and then we assess pathologic response. But at that point, we have this surrogate endpoint or marker of or prognostic marker of outcome. But we really can't do anything at that point because the studies of adjuvant therapy have not really shown much of a survival benefit. And the vast majority of our patients, they're not able to tolerate aggressive chemotherapy after an esophagectomy. So we really need to find ways to deliver adequate systemic therapy up front. So this really brings the question up, how can we predict which tumors will respond to which neoadjuvant therapy regimen? And how can we predict the good responders or poor responders up front so we can risk stratify and determine which patients we should be treating more intensively? And ultimately, how do we really individualize therapy based on novel biomarkers to improve outcomes? So we've heard this morning and just this previous talk that there are several biomarkers out there in esophageal and GE junction cancers. So I mentioned the ERCC1, there's MET gene amplification, HER2 that we've heard about, PD-L1 expression, and MSI high patients. These are all prognostic and predictive markers and may be able to determine specific targeted agents that we may use in these patients. But this still, as we kind of heard from Len Saltz, that this accounts for a very small percentage of patients with esophageal and GE junction tumors. So imaging assessments can also be considered as biomarkers in certain situations. And so we use imaging in oncology all the time. We use it pre-therapy as initial staging to determine eligibility and patient selection. And even in the pre-therapy setting, they can be prognostic and predictive. We often do imaging during therapy to evaluate response and have adaptive therapy options. And then following treatment for surveillance. So it's really, we already have imaging as part of our standard evaluation for patients. So what about PET imaging as a biomarker? So we know that this is a really nice, non-invasive way to evaluate the metabolic activity of tumor cells. And FDG uptake is associated with an increased rate of glycolysis and glucose transport. And in tumors, this can reflect a combination of proliferative activity and the number of viable tumor cells. And the SUV, or standard uptake value, is a semi-quantitative measure of that FDG uptake and metabolic activity of the tumor. And we know that for many cancers, metabolic activity is associated with outcome. So what about PET imaging in esophageal cancer specifically? So PET has been part of staging for about 20 years now, as some of the early studies showed that it was beneficial in terms of identifying distant metastatic disease in about 15% of patients beyond what we could identify with CT scans. And over the years, we've evaluated PET imaging for prognosis and as a predictive marker, as a baseline scan for baseline SUV, post-treatment SUV, and now, more recently, the change in the SUV from baseline to post-treatment. So some of the work that really established that use of metabolic response by PET as a biomarker comes from Germany, where they were looking at early PET scan assessment of patients receiving pre-op chemotherapy. So they did a baseline PET scan and then repeated a PET scan at day 14, and then patients continued on to complete their chemotherapy. Of the 37 patients who went on to surgery in this study, they were able to determine outcome by their PET response. And so they were able to differentiate two groups, both by the pathologic complete response and the time to progression, when they used a cutoff of the decrease in the SUV from the baseline to that repeat PET at 14 days of 35%. And so what they found was that the patients who were PET, what they called responders, at 2 years had a survival of 60% versus 37% for those who were PET non-responders. So this really showed that change in metabolic activity after the short course of treatment was prognostic for survival. So this led to the German group to do the MUNICON 1 trial and to really validate that, metabolic response as a biomarker. So they looked at 119 esophageal and GE junction adenocarcinoma patients. They received, they got a baseline PET scan and then received cis-5FU and had at 14 days after initiating therapy, they had a repeat PET scan. And then based on that the PET response, whether it was greater than or less than 35% decrease, they were deemed either non-responders or responders. PET non-responders went on directly to resection, and the PET responders continued on what seemed to be effective chemotherapy to complete 3 months, followed by surgical resection. And what they showed in this study was that the patients who were PET responders generally did better, as would be expected. They had a higher R0 resection rate, better major path response, and their median event-free survival and overall survival were also significantly better than the PET non-responders. But when they looked at this group of patients from the MUNICON trial and compared it to a previous study that had looked at a similar group of patients, but instead of changing therapy or going directly to surgery based on the poor response, they just completed the entire course of 3 months of chemotherapy. And so what's interesting about these data is that the PET responders in both groups did very well, but the PET non-responders who went directly to surgery had a median survival of 26 months versus those who went and completed what seemed to be ineffective therapy, went to surgery, had a median survival of 18 months. So potentially by intervening early and changing therapy based on the metabolic response, you can improve outcomes. And that this idea was validated in Dr. Ilsen's study looking at induction chemo followed by chemoradiation using, they used irinotecan and cisplatin. And they actually did their PET scan after the 2 cycles of cisplatin irinotecan, which was around 6 weeks into therapy, and then patients went on to surgery. And this study again showed there was a difference between the PET responders and PET non-responders, and they could still use that 35% decrease in the SUV as the cutoff to determine those 2 groups. So it's nice to see that you could actually use that same biomarker in, even at a different time point. And that what you can see here is the PET responders had a path CR rate of 32% versus only 4% in the PET non-responders, and a significant improvement in their median overall survival as well. The group in Germany decided to look at whether they could change therapy based on the PET response and see if they could improve outcomes by now adding radiation in the PET non-responders. And this study was designed to look at adding radiation with a dose of little bit of a strange dose. It was twice daily, 1.6 gray per twice daily for a total dose of 32 gray, which is actually quite a low dose of radiation. And they also they use cisplatin as a radiosensitizer. In the induction arm, they use 5-FU cisplatin plus or minus paclitaxel in patients, and so they didn't actually change the chemotherapy in the concurrent chemoradiation arm. So the non-responders went on to get this regimen of chemoradiation, and what they found was that actually these patients actually did worse than in the study where they went directly to surgery. So the median survival here was only 18.3 months, and there were very few pathologic complete responders in the arm that got that chemoradiation, which is quite surprising because usually we'd expect a better pathologic complete response if you're giving an adequate dose of radiation. So I think that one of the criticism for this study is, number one, it was very small, it was only 33 patients, but it also used a very ineffective salvage regimen. They continued on with cisplatin, and they used this very low radiation dose. So here in the US, this was based on work that was being done here at Sloan Kettering using induction chemotherapy followed by a PET scan to evaluate response, and then changing therapy based on if patients were having a poor response to their induction chemotherapy during the chemoradiation. So this was a study that we brought to the cooperative group, now the Alliance, so it used to be CALGB. It's the 80803 trial looking at PET-directed therapy for patients with esophageal and GE junction cancers. They all had to have a baseline PET scan. Then they were randomized to either of two induction courses of chemotherapy, FOLFOX or carbotaxol. Both have, as I've shown, have similar pathologic complete response rates with radiation. And then patients had a repeat PET scan. And based on the PET response, again, using the same 35% decrease in the SUV, if they had that decrease, they were considered PET responders, and they continued on the same chemotherapy with the radiation. We did 50.4 gray and 28 fractions, which is a very standard dose in the United States. And the non-responders crossed over to the alternative chemotherapy during the radiation, and then patients went on to surgery after 6 weeks. And the primary endpoint in the study was actually to look at whether we can improve the pathologic complete response rate, specifically in the PET non-responders, which we've seen in the previous slide, that it's about 4 to 5%, to see if we can improve that up to 20% by changing to an alternative chemotherapy during the radiation. One of the things that was challenging about doing a study where you include PET scans is that just the quality assurance, because you are dealing with institutions across the country. Even with in one institution, you can have differences in the PET scan parameters from one machine to another. So trying to standardize all of these PET parameters across the country was challenging. So we had to develop very stringent protocol guidelines to follow. We had funding to repeat PET scans if they didn't meet protocol specifications. And we also had real-time central PET review at the Imaging Core Lab at Ohio State University. They actually did these virtual site visits, so they did these site qualification and training meetings with the nuclear medicine physicians and the techs at each site. And then they also did a blinded read of the baseline and the post-induction chemotherapy PET scans to make sure that the readings were correct, and we would repeat scans if we felt that they weren't done correctly, and they also tracked everything. So this was an incredibly important part of this study. So just in terms of our patient population, we accrued 257 patients. The mean age was early 60s, and as expected in this population, the majority were male and white, and most patients had an ECOG performance status of 0. And the groups were well balanced. Most patients were T3, node positive, and were either lower esophagus or GE junction, and either moderately or poorly differentiated. And so after the induction chemotherapy, in the FOLFOX arm, 57% of patients were deemed PET responders, and the carbotaxol arm, 50% were deemed responders. And so the additional group were crossed over to the alternative chemotherapy. So these are the response rates in each group. So amongst the patients who had the induction FOLFOX and were PET responders and then continued on with the 5-FU oxaliplatin, their pathologic complete response rate was quite impressive of 37.5%. Amongst the PET non-responders who then switched over to carbotaxol, their path CR rate was 19%. For the induction carbotaxol group, the PET responders who continued on with carbotaxol had a path CR rate of only 12.5%, which was also surprising, was quite low. And the PET non-responders who went to FOLFOX had a path CR rate of 17%. So for all responders, the pathologic complete response rate was 26%. But for the non-responders, which were really the group that we were looking at, it was 18%. And so that actually met the efficacy criteria for that confidence interval around 20%. So it was positive in terms of our ability to improve the pathologic complete response rates for patients who changed therapy based on the PET response. So these are the survival results now for the patients with a median follow-up of 42 months. The median overall survival for all patients was 38 months. And here we see the response by the outcomes by response. So the median survival for the patients who were non-responders was 28.9 months versus responders was 47.3 months. And while the curves do separate, I think it's important to note that it actually was not significant. So we may be pushing, as opposed to the MUNICON trial where there was a significant difference, we're not seeing that significant difference. So we may be pushing that those poor responders a little bit higher up on the curve and improving their outcomes. These are now based on each of the subgroups, so the patients who got induction carbotaxol versus induction FOLFOX in the crossover group, so the non-responders non-responders in the solid lines, the responders in the dashed lines. And so you can see that the FOLFOX responders did the best. And even in the long term, actually, the carboplatin responders did pretty well as well. And here are the outcomes. So these are the median overall survival and 4-year overall survival for each group. And with this group that had that excellent pathologic complete response rate, we're also seeing that translate into this really pretty impressive 4-year overall survival rate of almost 53%, which is quite good. So just to conclude from the 80803 trial, we really showed that a short course of induction chemotherapy followed by early metabolic response assessment by PET imaging to direct changing from ineffective therapy to an alternative chemotherapy regimen during preoperative chemoradiation for these non-responders improved the pathologic complete response rate from an expected of 5% to 18%. And the survival data are reflecting this improvement and suggest that PET is a valid tool for tailoring therapy. And so what about comparing this with some of the other contemporary trials? It does appear that changing the chemotherapy does improve overall survival versus remaining on the same chemotherapy for PET non-responders. So in the MUNICON 1 trial, they didn't change they didn't actually add any more chemotherapy. They just went directly to surgery. So that was 26 months for median overall survival. For the MUNICON 2 trial, where they stayed on the cisplatin and gave an ineffective therapy with radiation, that median survival was only 18 months. And so in CALGB 80803, we have this median survival of 28 to 31 months for the PET non-responders. So we seem to be moving moving in the right direction for this poor risk group. The other question that comes up now, because of that disparate finding with the carbotaxol versus the FOLFOX, is FOLFOX the better regimen? The study was really not powered for a head-to-head comparison of FOLFOX and carbotaxol, but the results are hypothesis generating. And I think we can show with this study that by enriching the population based on an imaging biomarker to identify the responders to the initial chemotherapy with the FOLFOX resulted in a really excellent 4-year overall survival of 53%, versus when you look at the cross trial for all comers, unselected patients, their 4-year overall survival was only 45%. There is a study going on in the UK now, the SCOPE 2 trial, that's looking at using early PET response to direct chemo changes as well as radiation dose. So on the adenocarcinoma, in the adenocarcinoma study, they're doing PET scans, and if based on the PET response, the patients who are PET non-responders are randomized to either changing chemotherapy or a different radiation dose. PET responders are randomized to just 2 different radiation doses. And then the next steps, I think we're really hoping to see some interesting outcomes from the correlative studies that have been, we've collected, the tissue, serum, plasma, and whole blood from our patients. And now the next step is really to correlate some of the exciting work that's being done here at Sloan Kettering, what we've heard already this morning about looking at some of the biomarkers, using MSK impact testing, baseline ctDNA levels to predict outcomes, serum cytokines, and looking at some of the tumor immune microenvironment potential predictors for how patients do. And Jeff Koo is going to be leading this effort, and David Ilson has also made this possible by securing philanthropic funds. So that's very exciting. So just in summary, I think the CALGB 80803 trial is really a unique study evaluating a very standard imaging modality. It's non-invasive. It's something that's covered generally by insurance and is pretty much incorporated into daily practice for early response assessment to help us direct therapy for patients with esophageal and GE junction cancer. It's really validated a new paradigm of using metabolic imaging to individualize multimodality therapy and improve outcomes in this poor prognosis population. But I think what I'm hearing this morning is really exciting, what I heard this morning about really what are the emerging biomarkers out there. And so I think we really need to both identify and then validate, because it takes a lot of work to even validate these biomarkers to help us guide the therapeutic decisions and individualize therapy for patients with esophagogastric cancers. So I'd like to thank David and all my colleagues here at Memorial Sloan Kettering. It's been 3 years since I left, and it's great to be back. And I'd like to thank all of the people that I worked with at the Alliance and all the patients who were involved in the CALGB 80803. And this is the view here from where I work in Colorado. And thank you for your attention.